Hello, my dear doctors. So, today I'm going to talk a bit about Mrcp basis neurology station, and we're going to discuss about the case of peripheral neuropathy. And this case is, believe me, is very common in neurology station. So, let's start. So, as you know, this is a short station, so we're not going to take any history from the patient. Normally, there will be there will be some command, just examine the patient lower limbs, or patient has difficulty in walking, examination of the lower limbs, or maybe there could be some other prompt like examination of the upper limbs, or maybe sometimes they say that patient has difficulty in speaking or got some weakness, or there could be anything will be there in the scenario, so you have to proceed accordingly. So normally for the peripheral neuropathy they will put the command that examination of the lower limbs, patient has difficulty walking or patient has some weakness. So once you read the scenario, then you know already that you're going to focus on the mainly on the lower limb examination. But definitely, if you have time, it is a good idea to do the upper limb examination as well, and uh, brief cranial nerve examination. So same thing. First of all, we're going to do our introduction and setting. So introduce yourself to the patient, ensure privacy and comfort. Then the second step is to first of all is the introduction, and then we move on and do the general inspection. So just observe the patient posture, gait, and any signs of discomfort, and look for any obvious deformities or asymmetry in the limb. So it's just a general inspection. Then I put here cranial nerve examination. Normally it is not needed. Normally it will come into the end. For because if the command is do the lower limb examination, just you go through the lower limb examination, and if needed, maybe you can do the cranial nerve examination as well, if it is relevant. And if it comes up in the long case or the consultation station, then obviously you're going to do the cranial nerve examination as well. So after that, we're going to perform the motor examination. So assess the muscle bulk, tone, and symmetry. Test for muscle strength in all major muscle groups. We use the MRC grading system, and note any sign of muscle wasting or fasciculations. So after this, we're going to do the sensory examination. So test the light touch sensation using a cotton wisp or tissue paper, and assess the proprioception by testing joint position sense, evaluate pain and temperature sensation using a pin prick, and perform vibration sense using a tuning fork. So all four modalities you have to check in the sensory examination. Then you're going to check for the reflexes as well. So check deep tendon reflexes. Normally, if it is a lower limb, just we're going to concentrate on the knee reflex and ankle reflex. If it is upper limb, bicep, tricep, and big radiated reflex. Coordination and balance. So assess fine motor coordination using the finger and heel shin test, and evaluate gait for any abnormalities like ataxia or imbalance. We're going to do the Romberg's test, how we're going to do this. We assess the patient ability to stand with feet together, first with eye opens and then with eyes closed. So note any worsening of balance with eyes closed, indicative of sensory ataxia. We briefly going to do the peripheral vascular examination as well. Just checks the peripheral pulses, especially the dorsalis paris and the posterior tibial, and assess for any signs of peripheral vascular disease. And then we're going to summarize the key findings and discuss the potential differential diagnosis and investigation. So in the examination, just try to be systematic. Always start with the general inspection, and then move on to do motor sensory examination, reflex examination, look for any cerebellar sign, do the Romberg test, and peripheral vascular examination. So what are the positive findings which are associated with the peripheral neuropathy? Positive findings: we may have a muscle weakness, may have atrophy or fasciculations, maybe some impairment of sensation like numbness, tingling, or loss of proprioception, maybe hyporeflexia or areflexia, positive Romberg test indicating the sensory ataxia, and abnormal gait, for example, high steppage gait due to foot drop. So any of these findings can be there in the peripheral neuropathy case. Briefly, I'm going to talk about the differential diagnosis. Normally, most of the time, I must say around 70% of the time, it is diabetic neuropathy. So it is diabetic neuropathy. We know it is common in individual with diabetes, and it presents with distal symmetric polyneuropathy, and usually there's gradual onset of numbness, tingling, and pain in the feet and hands. Alcoholic neuropathy, obviously, it is associated with the chronic alcohol use, and it also presents with sensory symptoms. But the additional thing is there may be some ataxia as well. Vitamin deficiencies, another differential diagnosis is vitamin deficiencies, and vitamin B12 deficiency can lead to peripheral neuropathy. And consider other nutrition deficiencies as well, like thiamine deficiencies, or vernix encephalopathy. Toxic neuropathy, well, exposure to toxins or medications, chemotherapeutic agents, certain antibiotics. If it is a long case, obviously history of occupational or environmental exposure should be explored. So remember, always know about the differential diagnosis of the peripheral neuropathy. Divide in different groups, then it will be quite easy for you. Diabetes, alcohol, vitamin deficiency, toxicity, and then think about some, I'll put here infectious causes as well in the differential diagnosis, like GB syndrome. Usually it is acute onset with ascending weakness and areflexia, and is often preceded by infection. Another infectious disease causes Lyme disease. Autoimmune neuropathies, chronic inflammatory demyelinating neuropathy. Usually there is a gradual onset of symmetric weakness and sensory symptoms, and there is progressive or relapsing remitting course. SLE also is one of the cause of autonomic neuropathy. Hereditary neuropathies, Charcot-Marie tooth disease and other genetic neuropathies, and family histories may provide a common clue. Metabolic causes like renal failure and hypothyroidism can also lead to peripheral neuropathy. Paraneoplastic neuropathy, sometimes neuropathy is associated with an underlying malignancy, which may precede or coincide with the cancer diagnosis. And finally, it can be idiopathic neuropathy as well. Some cases, they may not have a clear underlying causes. So I put a lot of differential diagnosis for the neuropathy. It is important to remember this, because very common question they will ask, what are the causes of the peripheral neuropathy, or what is the differential diagnosis. So remember this is, especially try to remember the main one, like diabetic, alcoholic, vitamin deficiencies, toxic, infectious causes, and autoimmune neuropathies. Okay, so how going to what should be our diagnosis approach? So detailed history, obviously, if it is a short case, then we're not allowed to take any history. But if it comes in the consultation stage, then we will be interested in the detailed history. We want to know about the onset and duration. So obviously establish when the symptom began and how they have progressed over time. We want to know about the nature of the sensory symptoms, like tingling, numbness, pain, and any associated motor symptom. Will also do some systemic review, inquire about other symptoms like weakness, gait disturbance, and autonomic symptoms, and occupational environmental exposure, explore exposure to toxins or chemicals that could contribute to neuropathy. Then obviously we're going to proceed with the clinical examination, neurological examination. Same thing is we have to assess sensory and motor function in systematic manner. We're going to check for reflexes, muscle strength, coordination, and gait. So with the examination, we may have some idea about the cause of the peripheral neuropathy. Then we're going to do some blood tests. We want to do the CBC to rule out anemia or any signs of systemic inflammation. Blood glucose level to screen for any diabetes, vitamin B12 levels to test for nutrition deficiency, and thyroid function test to assess the thyroid function. I put this blood test here. Sometimes they ask how you're going to investigate. So one, you can see that one is the blood test. Then other investigations include the nerve conduction studies and EMG, and these help determine the type and extent of nerve damage So different patterns on these tests may point towards specific neuropathic conditions. We also be interested in doing some autoimmune inflammatory markers, especially ANA, to screen for any autoimmune disorder, ESR and CRP, which are indicators of inflammation. Infectious disease screen, well, based on the clinical suspicion, consider tests for infectious causes such as Lyme disease, although it's quite rare. Imaging studies like MRI of the spine if there's a suspicion of structural disease affecting the nerves. Nerve biopsy sometimes is indicated. It may provide some diagnostic information. Genetic testing. If hereditary neuropathies are suspected based on family history or clinical finding, we'll be interested in doing some genetic testing as well as and collaboration with the specialist. So consider referral to a neurologist for further evaluation and interpretation of diagnostic tests. So this should be our approach: detailed history, clinical examination, and then followed by some investigation. Again, depending on the what cause you are thinking about, then you're going to proceed further with the just mention about the appropriate investigation plan you have considering the cause of the peripheral neuropathy. So case presentation, I put here peripheral neuropathy in a patient suspected due to diabetes mellitus. So sometimes there are some clues there. While you are examining the patient, you may see some needle prick marks on the pulp of the fingers, which suggests the patient has been doing this blood glucose monitoring. So that is one of the clue that you may find in the hands, and then it will lead to the diagnosis of the peripheral neuropathy may be likely due to diabetes. So here I put a model case presentation, peripheral neuropathy in a patient suspected due to diabetes. So how are we going to present the case? So this is a case of a 55-year-old male with suspected peripheral neuropathy likely secondary to diabetes mellitus. And then you're going to put the examination findings. So likely secondary to diabetes mellitus, how you come how you know that patient has diabetes? There may be some clues. Sometimes there is an insulin syringe there at the bedside. Maybe some tablets there like oral hypoglycemic drug. Maybe you were able to see the needle prick marks on the um, pulp of the fingers. So in that case, you are sure that this patient is most likely the peripheral neuropathy is because of the diabetes. So you can put this diagnosis. Otherwise, if you don't find any clues, you can just say that patient has peripheral neuropathy, and then you're going to talk about the differential diagnosis, which I have discussed already. So introduction and then examination findings. You're going to talk about the examination finding. I have done the sensory examination. There is reduced sensation to light touch and pinprick in a stocking and glove distribution, and absent vibration sense at the grade 2. Motor examination, muscle strength in lower limb is preserved. Reduced ankle reflexes bilaterally. In coordination and gait, there is normal coordination. Gait is wide-paced with difficulty in heel to toe walking. Vascular examination, we have palpable pedal pulses and no signs of peripheral vascular disease. So I put these headings that once you're giving your presentation, it is better to keep these headings in mind so that you don't miss anything. To talk about sensory examination, talk about motor examination, coordination and gait, and vascular examination. So then you're going to talk a bit about the differential diagnosis. If there's some clue, is okay. If there's no clue, then you say you can just mention these differential diagnoses like diabetic neuropathy, given the patient. If there is a consultation station may have a history of diabetes mellitus, diabetic neuropathy is a primary consideration. Peripheral arterial disease, pedal pulses are palpable, consideration of concomitant peripheral arterial disease, Charcot-Marie teeth disease. This is inherited neuropathy that can present with sensory and motor deficit. Alcoholic neuropathy, if the patient has a history of alcohol, otherwise you just put in your differential. CIDP, autoimmune neuropathy with a chronic progressive course, and lumbosacral radiculopathy, which is compression of lumbar or sacral nerve roots leading to similar symptoms. So if there's no clue, then you just mention that my differential diagnosis include diabetic neuropathy, peripheral arterial disease, Charcot-Marie tooth disease, alcoholic neuropathy, chronic inflammatory demyelinating neuropathy, and lumbosacral radiculopathy. In Charcot-Marie-Tooth disease, remember it is because it's a long-standing disease. So you have mainly you'll be seeing atrophy of the muscles, and the gait is high stoppage gait. Okay, so then you're going to summarize. The patient presents with sensory and reflex abnormalities, raising suspicion of peripheral neuropathy. So, considering the history of diabetes mellitus, diabetic neuropathy is the leading differential diagnosis. However, other etiologies such as peripheral arterial disease, genetic neuropathies, alcohol-related neuropathy, and inflammatory conditions should be considered. So this is how you're going to present. You're going to introduce examination finding, talk a bit about differential diagnosis, and then finally um, conclude it with a summary. So management approach for peripheral neuropathy suspected due to diabetes mellitus. We're going to do the confirmation of the diagnosis. Same things, we're going to do nerve conduction studies and EMG to confirm the presence and extent of neuropathy. I'm going to perform some blood tests like hemoglobin A1C to assess long-term glycemic control. Glycemic control, optimize glycemic control to slow the progression of neuropathy and adjust the diabetes medications, lifestyle modification, and reinforce the importance of regular monitoring. These are the further questions. The examiner may ask you that, okay, how this peripheral neuropathy is because of the diabetes. How are you going to approach this case now? So first of all, confirmation of the diagnosis. We want to know about the glycemic control. We want to optimize the glycemic control. Then symptomatic relief. So neuropathic pain management. Initiate medications like gabapentin, pregabalin, or amitriptyline for pain relief, and consider topical agents such as capsaicin cream. Physical therapy. Prescribe exercises to improve strength, balance, and coordination, and encourage regular physical activity to enhance the circulation. Foot care is important, so emphasize meticulous foot care to prevent injuries and infections, and we have to provide guidance on proper footwear and regular foot inspection. Lifestyle modifications, address modifiable risk factors like smoking, again excessive alcohol consumption, and encourage a healthy diet and regular exercise. Multidisciplinary care, remember this is a buzzword and you must mention in all the chronic cases that do we're going to involve the other specialties, so it will be multidisciplinary care. Collaborate with specialists including endocrinologists, neurologists, and physical therapists. Involve a dietitian for nutritional counseling. Monitoring and follow-up. Schedule the regular follow-up appointment to assess symptoms progression and treatment efficacy. Adjust the management plan based on the patient response. Patient education is very important, so educate the patient on the chronic nature of neuropathy and the importance of long-term management. Address any comorbidities, manage comorbid conditions like hypertension and dyslipidemia, and ensure regular screening for associated complications. So this is how we're going to approach the case. Some of the questions which the examiner may ask: can you explain the common causes of peripheral neuropathy? Again, this repetition, and I'm repeating it again and again because these are the these are very common questions which the examiner asks. So you must be very much familiar with these questions, and all the answers should be prepared because in the exam you'll be under a lot of stress. There is not much time, so I must say that all your answers should be at the spinal cord level, so that you should answer promptly. And these are all questions. We know that what questions will be asked, so it's better to prepare yourself for these. So answer is peripheral neuropathy can be caused by various factors including diabetes mellitus, alcohol use, genetic conditions like Charcot-Marie-Tooth disease, inflammatory conditions like CIDP, and certain medications. Another question: how do you confirm the diagnosis of peripheral neuropathy? What investigation would you order? To confirm the diagnosis, I will conduct nerve conduction studies and EMG, and these tests help assess the electric conduction in nerves and muscle response, providing valuable information about the presence and severity of neuropathy. Another common question: what is the significance of glycemic control in a patient with diabetes and peripheral neuropathy? So glycemic control is crucial in managing peripheral neuropathy and diabetes. Optimal blood glucose level, they help prevent further nerve damage and may even improve symptoms. So it is an essential component of comprehensive care for diabetic neuropathy. How would you address the patient pain associated with peripheral neuropathy? Common question. So pain management is a key aspect. I would consider medications like gabapentin or pregabalin for neuropathic pain relief. Additionally, drugs like amitriptyline or duloxetine can be used. It's important to tailor the treatment based on the patient response and tolerance. What advice would you give to the patient regarding foot care? Again, this is a repetition. I would emphasize the importance of meticulous foot care to prevent complications. This include daily foot inspection, wearing proper footwear, and avoiding activities that may cause trauma. Regular podiatry assessment would also be beneficial. Okay, another question, how do you assess and manage the patient risk of fall considering the neuropathy? So in this, a comprehensive approach involves physical therapy to improve strength and balance. I would also assess the home environment for safety measures. A regular follow-up to monitor gait and coordination is essential to prevent falls. So what red flags in the history or examination would prompt you to consider alternative diagnosis or further investigations? Red flags may include sudden onset, asymmetrical involvement, proximal muscle weakness, or the presence of constitutional symptoms. So these will prompt further investigations such as imaging studies to rule out compressive neuropathies or vasculitis. So remember these red flags. This question is also quite common. How would you educate the patient about the long-term management of diabetic peripheral neuropathy? So patient education is vital. I will discuss the importance of strict glycemic control, regular food care, and the need for ongoing monitoring. Explaining the chronic nature of neuropathy and the role of medications in symptoms management is essential for patient understanding and compliance. Potential complications of peripheral neuropathy and diabetes, how would you screen for them? Complications may include foot ulcers, infections, and Charcot arthropathy. Regular foot examination, including sensory and vascular assessment, are crucial. I would also advise regular eye examination for diabetic retinopathy and cardiovascular risk assessment. So in managing neuropathic pain, what are the considerations when choosing between medications such as gabapentin and amitriptyline? So the choice between medications depend on factors such as nature of pain, patient comorbidities, and potential side effects. Gabapentin is effective for neuropathic pain and is well tolerated. Amitriptyline, a tricyclic antidepressant, is also effective but may have more side effects. So the choice is based on individualized approach. How would you address the patient's psychological well-being in the context of chronic diabetic peripheral neuropathy? So chronic conditions can impact psychological well-being. I would assess the patient mental health and consider referral to a psychologist or counselor if needed. Support groups and patient education on coping strategies can also be beneficial. And discuss the role of multidisciplinary care in managing a patient with diabetic neuropathy. So our multidisciplinary approach involves collaboration with various healthcare professionals, including endocrinologists, neurologists, podiatrists, physiotherapists, and dietitians, and this ensures comprehensive care addressing glycemic control, symptom management, foot care, and lifestyle modifications. So, my dear doctors, I've tried to cover almost everything which could be asked in a peripheral neuropathy case. Please practice your skills, especially the neurological examination of the lower limbs, um, upper limbs, cranial nerves, all these, and try to um, do as many cases as possible. I will recommend at least 20 cases you should do for the peripheral neuropathy so that your examination skills are very swift and uh, so that you can do it very well in your examination. Thank you very much, and I'll see you in my next presentation.